by about 16% over the last few months. And then our expense structure remains relatively unchanged with those contracts and physicians and assistants. So we closed the year at a claim at 14.6 million. If you look on the next page, when you combine the activity of the medical center and a claim, we closed the year operating margin at 183.1 million and a net income of about $198 million. So I apologize about some of the technical difficulties that we had, but I hope we were able to follow along and get through the year-end presentation. I'll be happy to answer any questions if there are any. Okay.
Thank you all very much for that. And Sharon, thanks for the presentation. It has been a different year. And I think to Charlie's point, DT's point, and even Dorothy's points and Steve's, going the conservative route is a good way to go. And it's smart the way we're doing things. We will definitely fight for those dollars. But we've had a very interesting financial year. And we've been the recipient, thank goodness, of some beneficial decisions in other matters that the federal government has made on formula funding. But those decisions were against us for the past 5 years. So I don't want to look at the fact that we've got this unbelievable windfall without taking into consideration the 5 years of losses that the formula funding went against JPS and most other public hospitals. So Sharon, I applaud you and your team. You've done a good job at year end. And I'm really excited that we are very much in sync with the board and the philosophy at which we're going, and BKD working with us as well. So, Mr. Chair, that's the report from there.
Thank you very much. There's no further questions. I'll consider a motion on item A, acceptance of the financial report from Ms. Clark.
For approval. I'd make a motion for approval.
We have a motion from DT, a second from Mr. Powell. All in favor, please say aye.
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 Opposed? Motion passes. Thank you, everyone. We'll move on to item B. I'm very happy and delighted, actually, that we're getting this presentation. Rory, are you on the call?
Yes, sir. Thank you, Mr. Chairman. Please alert me if you can hear me.
Yes, we can.
Many of you know from the headlines over the last couple of years, the subject of veterans' access to health care has been on the forefront. Not only access to care, but the quality of care and generally how veterans access care within the healthcare system. Around August 1st, Mr. Early alerted me to kind of take another look at maybe perhaps why we were not contracted to be able to care for the veterans. And so, although veterans receive care in the emergency room, many times if they were admitted, they were asked to be transferred to another facility, perhaps over in Dallas or somewhere else. So it created a lot of confusion for our veterans as well as complexities. And so Tammy Jones, Kelly Ford, and the managed care team have taken on this issue and have gotten this contract before you today. So the contract is with Blue Cross of Texas. To clear up a little confusion, Tri-West actually subcontracts with Blue Cross to develop a network for the veterans. And so Blue Cross and several other states, Blue Cross of Texas and other states, have an ownership interest in Tri-West. So I just wanted to clear up a little confusion on why it's with Blue Cross and not Tri-West. What we're asking for is approval for the contract today, and it'll allow us to provide in-network care for veterans. And we're really thankful that we have the opportunity to do that. It's a big win for JPS and for our veterans. So I'll take questions right now.
Great. This is a big deal, guys. I'm really, really proud of Rory and everyone who participated in this. Tip of the hat to everybody. Any questions for Rory?
Rory, were the rates consistent with the rates that we negotiate with Blue Cross on our other payers?
So with respect to rates, we could talk in generalities. It would not be comparable to a commercial rate. It would be comparable more to a Medicare or TRICARE military rate. So we would not expect to see commercial rates on veterans because they just don't pay in that percentage or that realm.
But overall, financially, it becomes really sort of a break even for us relative to our overall patient population, right?
Yeah, certainly not tremendously worse on a rate structure, well above Medicaid rates, more on par with Medicare. I hope I'm answering your question.
Yeah, no, that's great. I just wanted to get the financial kind of picture of it, but congratulations. This is a gigantic step and probably been needed a long, long time.
I agree, Trent.
Absolutely.
I will say, Mr. Chair, you complimented Rory and his team, but when I made the suggestion to Rory, he readily picked up that ball and ran with it. And the challenge that we have with our veterans, particularly here in Tarrant County, is any specialty care that they need, it's mostly provided for in Dallas. And many of our veterans are getting to a stage, if you look at our Vietnam veterans and others that travel back and forth from Fort Worth to Dallas can be very, very complicated and difficult, particularly when you're in need. And then you look at that region as being the major center for everybody. I know that no disrespect to the VA, they're doing the best they can, but wait times are a challenge and other things become very challenging. We want to be able to be there to help our veterans. And I really applaud Rory and his team for taking this initiative. And I'm thankful that you board members are supportive of this. I think this will be huge from a mental health standpoint, behavioral health standpoint, the challenges of substance abuse, but also the need of a growing older veteran population that oftentimes doesn't find the care that they need. I think JPS will be there for them as a partner with the VA in helping them.
Mr. Chairman? Mr. Chairman? Mr. Chairman?
Yes, sir.
Steve, I don't know when you're going to call for a motion, but I think obviously this is something I'm very excited about. I know the rest of the board is too. I know we have several veterans on the board. I would certainly yield to any of those veterans if they wanted to make the motion in second. I just make that as a point of reference.
Excellent point.
Yeah, Charlie, I agree. I do a lot of work, particularly with the wounded veterans and returning heroes. And this gives them an option that they've been sorely missing. And so I'm excited to see JPS coming in and filling that void.
Agreed. So with that, if there are no further questions, I'd like to ask for a motion on item 7B. Perhaps Dr. Weber?
So moved.
We have a motion by Dr. Weber. Looks like Reverend Emerson has stepped away.
Oh, okay.
Second by Dorothy.
Second by Mr. Bose. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you all.
Thank you.
Item C, Ms. Parker.
All right. Well, good morning, everyone. I'm here to present the C-SPAN agreement. That is our colorectal cancer screening and patient navigation agreement that we have with UT Southwestern Moncrief. Moncrief, through their Cancer Institute, has funding through a grant through the Cancer Prevention Institute of Texas, CPRIT. And so that funding actually helps to provide support for those that maybe struggle with ability to pay for cancer screening, for colorectal FIT tests, as well as it helps to provide some funding for follow-up such as colonoscopies. And so JPS is that provider. We help support in navigation for those patients identified for the colorectal screening, as well as those colonoscopies. And then we are reimbursed at a Medicare allowable rate. And so certainly I will credit a little bit of this to the support that has helped us to achieve, from a district perspective, advancement in our cancer screening and early detection that we've been able to do with our team this year. So it's a benefit from a health outcomes perspective for our patients, as really it's a great support for JPS. And so I'm in full support of us to continue this program in partnership with Moncrief. And I'm happy to answer any questions.
Any questions for Joy?
This is Zim for approval.
We have a motion for approval. Do I hear a second?
Second.
Second from DT. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, Joy.
Thank you.
The next three items on the list are the three contracts we've just approved in planning committee. We do have to take them one at a time, but it's one of the alerts you that they may look familiar. Item D is the professional services agreement with Lockwood, Andrews, and Newman. I believe we're all familiar. If there's no questions, I'll entertain a motion.
Move approval.
Second.
Well, I think I heard a motion from Mr. Bose, a second from Mr. Petty. All in favor, please say aye.
Aye.
Opposed? Motion passes. Item E is professional services agreement between Jensen Hughes and Tarrant County Hospital District. If there are no further questions, I'll entertain a motion.
Zimmerman, move to approve.
Then move to approve. Do I hear a second?
Second from me.
Second from Dr. Weber. All in favor, please say aye.
Aye.
Opposed? Motion passes. Item F is a professional services agreement between DryTech and Tarrant County Hospital District. If there are no further questions, I'll entertain a motion.
Move approval.
Motion by Mr. Bose. Do I hear a second?
Second.
Second from DT Win. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you all. Item G, Mr. Lane. Was this one? No, this isn't one we've already done, right?
No.
Okay, Mr. Lane.
Yes, sir. So I am presenting a couple of contracts for David Mendenhall. He is on PTO. So not to upset the natural order of things, if there are any concerns on these, we will go to our default position that it's David's fault. So the first contract is for GE Medical Systems. This is an extension of a contract that was already approved by the Finance Committee. This was for
I think this is, I'm sorry to interrupt you. I think this is Hologic. The
I'm sorry, I've got them reversed here. So this one, Hologic, we have digital mammography from Hologic, and this is a service agreement by Hologic on their systems. They're the only providers of service on their systems, and Hologic is the bellwether standard for digital mammography.
Do we have any questions for Adam? Please come up with some, just to stump him.
Move to approve.
All right, we have a motion to approve. Do we hear a second?
Second.
Second from Mr. Wynn. All in favor, please say aye.
Aye.
Opposed? Motion passes.
Mr. Chairman, I would note that Mr. Mendenhall is obviously on PTO, and you notice that he asked one of the newest members of the staff to present his needs. He didn't go to one of the older members of the team or more seasoned members of the team. He went to the newer members of the team. So applause to Mr. Mendenhall on these tactics.
Yeah, we're on to his game.
Yeah, and he gave us the most complicated diversity report I've ever seen.
That's true.
All right. Item H, Mr. Lane.
Yes, so this is for the continuation of the GE telemetry system. The Finance Committee and the board have approved phase 1 of that previously for Tower 1 through 8. This is for Tower 2, 3, 4, and the endoscopy components of that. This is number 2, I believe, of 3. The third may come in the future, but this is $772,000 in operational expenses.
Okay. Any questions for Adam? Entertain a motion.
For approval. Second.
Motion by Mr. Wynn, a second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Mr. Lane. Appreciate that.
You didn't call me out again?
Yes.
Call me out again like last week?
We'll get you. Come on. We'll stay.
I won't believe the vicious rumor that you were just lonely.
Yeah.
Well, you know.
Don't poke the bear, Adam. Don't poke the bear. Just keep going.
Item I. Julia, Roll Tide Ball. Are you around?
I am. Roll Tide. It just comes out of your mouth. Sorry. I'm here today to present to the board a contract with Translogic Corporation doing business as Smith Log Healthcare. And it's two parts. One, an exemption to competitive bidding. And the reason for that is this is a unique medication dispensing system for the jail only, and we currently have this in our jail. The second part is your approval in purchasing a new Swiss log machine to replace the current Swiss log machine at the Lamar facility. It's over 6 years old. And currently this machine is dispensing about 3 million pills a year. And so the usage of this equipment is extremely high, and it's important to be functioning at its highest level. And so that is why I am requesting both of these from the board.
Okay, we'll take them separately. And so there are two different votes for each one of these, right? For I and J.
How different is this from the Pyxis system?
DT, this machine is preloaded with pills from the pharmacy, and it connects with the MAR, the medication administration system per inmate. And so it puts the pills into one packet and then labels that packet with the inmate's name and date of birth. And then that packet is loaded into a locking medicine cart and is taken to the floors of the jail to dispense to each inmate.
Oh, I see. To control substance and everything else, time lock and everything.
That and having the proper medication to the right inmate. And prior to JPS purchasing this system 6 years ago, this was a manual process. And it was a big encumbrance on productivity as well as quality.
Yes, ma'am. Thank you.
Sure, thank you.
So for item I, I'll entertain a motion, a two-part motion for the exemption to competitive bid and for the item itself. Do I hear a motion?
This is Dorothy, and I will make a motion to approve the exemption and the purchase.
I'd second, Steve.
We have a motion from Ms. DeBose, second from Mr. Powell. All in favor, please say aye.
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 Opposed? Motion passes. Item J, same scenario. I hear a motion.
Move approval for the exemption and the purchase.
Zim, second.
Thank you, Mr. Bose. We have a motion by Mr. Bose, a second by Mr. Zimmerman. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, everyone. Thank you, Zelia. Oh, we have another couple for you.
Two more.
Item K.
I'm on a roll this week.
You are. Roll Tide.
Oh, that was good.
I'm presenting today to the board for your approval of a professional services agreement between JPS and MHMR for us to provide indigent services to adult and adolescents in need of crisis mental health services. This is actually a revenue contract. MHMR will be paying us a little bit over $2.3 million annually for this 1 year to provide this service to the community. And this is a contract that we had last year.
Okay.
Move to approve, Steve Trent.
We have a motion from Mr. Petty. Do I hear a second?
Second.
Second from Mr. Powell. All in favor, please say aye.
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 Opposed? Motion passes. Thank you, everyone. Thank you, Zelia. Item L.
Okay, this is another revenue contract. This is a professional service agreement between JPS, inpatient mental health services for the involuntary commitments with MHMR of Tarrant County in the hospital district. This helps reimburse for some of our costs for the LCA beds that we currently provide. And actually, this is a revenue increase from last year of approximately $444,000. MHMR was able to get us some more money in order to help compensate for the COVID-19 things that we've been doing here on inpatient as a result of working with our vulnerable population.
Great. Nice to hear. Any questions for Zelia? Entertain a motion.
This is Dorothy. Move approval.
Motion by Mr. Bose.
Second.
Second from Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Zelia.
Thank you.
Item N, Mr. Dubuclet.
Hello, Mr. Chairman and Board. I am here today to request your approval on a services agreement between Symetra Life Insurance Company and Tarrant County Hospital District. This agreement provides employees supplemental benefits for basic life, long-term disability, and other short-term disability and other options. They can increase their voluntary life insurance coverage, et cetera. This is an annual savings of $288,000. Total contract savings over 3 years, approximately $865,000. This was an agreement that played a significant role in keeping the price of benefits to our employees flat this year.
Okay. Any questions for Mr. Dubuclet?
Hello. What constituted the savings? What was the mechanism that made the large savings?
Quite frankly, it was more about our ability to negotiate with them and to reduce the cost. Essentially, we were able to manage some components of the policies that were offered to a point where we negotiated effectively to get the rates down. And that's essentially what it was, a great job of negotiating by our team.
Wonderful work. Thank you.
Okay.
Thank you.
We didn't vote on that one, right? Vote on item N. I'll entertain a motion.
Move to approve.
Second.
All right, we have a motion and a second. All in favor, please say aye.
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 Opposed? Motion passes. Thank you very much. Item N, Dubuclet.
Thank you again, Mr. Chairman and Board. Here requesting your approval on a second amendment to the Employee Pharmacy Benefit Management Services Agreement with Maxor Plus Limited. This is a second amendment. I will just remind the Board that the first amendment that occurred for this agreement was simply an adjustment to the date, aligning it with the other two Maxor contracts that we have with them. This amendment provides a savings of approximately $1.2 million. It continues the great partnership that we have with Maxor, and this covers all of the employee pharmacy benefit management services. So essentially, for every employee that elects benefits coverage, they have access to a great pharmacy benefit, which reduces the cost significantly to the organization and ultimately to the employees as well.
Okay. We've heard the explanation. Any questions?
Is this a renewal or?
No, it is not. It is simply an amendment adjusting an amendment suggesting that we continue the partnership to ensure that the savings continues for our employees.
Okay. Same formulary and everything else? Any changes in that?
None at all.
All right, thank you.
It is just a reduction in rates. So I guess in that way, it's a formula change, but to our benefit.
Yes, sir. Thank
you.
Okay. Any other questions? I'll entertain a motion on item N.
Move for approval.
Motion by Mr. Nguyen.
Second.
Second from Mr. Bose. All in favor, please say aye.
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 Opposed? Motion passes. Thank you. Dr. Elliott.
Hello.
Good morning.
Good morning. Good morning. I'm here presenting two professional services agreements. The first I'll start with is a professional agreement with Apoorva Deshpande with the Tarrant County Hospital District. And the second will be with Ala Ellis Shear. These two clinical research coordinators have been with us in performing behavioral health research. However, they've been under an acclaimed contract. And in our efforts to improve efficiency and centralize our research activities under our Office of Clinical Research, we are asking for these professional service agreements. They've been doing a remarkable job, and we want to make sure they continue the work of our behavioral health clinical trials. Asking for the first one for consideration of approval.
Any questions for Dr. Elliott? Okay, entertain a motion.
Recommend approval.
Second.
We have a motion and a second. All in favor, please say aye.
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 Opposed? Motion passes. Item P, entertaining motion.
Move
Did I hear, did I hear a motion from Mr. Bose?
Yes.
We have a motion. Do I hear a second?
Second.
Second from Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you all. Thank you, Dr. Elliott.
Thank you, guys.
Mr. Chung, talk about newbies. This is your first time at bat.
Yes, absolutely. So go easy on me.
No way.
Thank you. So I'm here to present the second amendment to our comprehensive pharmacy management services agreement between Maxor and Tarrant County Hospital District. So what this amendment does is add additional coverage for pharmacy services to our inmate population out at our correctional health sites. It's a $600,000 annual increase and $750,000 over the 15 months that this contract overall is active for. So, any questions on that one?
Any questions for Doug on this? Okay, entertaining motion.
This is Zim, move to approve.
Motion by Mr. Zimmerman,
Second.
second by Mr. Bose. All in favor, please say aye.
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 Opposed? Sorry, Doug. Doesn't look like it passed. Maybe next time. All right, it passed unanimously. Thank you. Item R.
All right, so this agreement is between Care Fusion Solutions and Tarrant County Hospital District. This is a total about $1.2 million annually, and what this agreement does is expand and really bring in some new equipment for our Pyxis machines that was mentioned earlier by Mr. Nguyen. So we are going to come in, replace all of our Pyxis machines in all of our units across the hospital, and it's just time that lease is out, and so this lease will begin, and we'll be able to begin that work in the coming months. There's about 101 of these units across the enterprise, and really no year-over-year expense with this lease agreement.
Okay, any questions for Doug on this? Entertaining motion.
Move approval.
Motion from Mr. Bose.
Second.
Second, Mr. Nguyen, did I hear a question in there? Okay. All in favor, please say aye.
Aye.
Aye. Opposed? Wow, another one. Doug, sorry, that's two down. Motion passed.
Let's go. Let's bat for 1,000 here.
There we go.
All right.
Item S.
So this final agreement is the first amendment to a multi-year reagent capacity expansion agreement between Cepheid and Tarrant County Hospital District. And so what this agreement does, we already have this unit in-house. It's going to expand the capacity and the number of tests that we are able to run simultaneously on this agreement. And one of the important notes, we have about half the capacity here today. They will give us the other half of the capacity, running the machine at 48 tests at a time. It'll expand our ability to run more COVID testing, decreasing our turnaround times for our COVID testing as well too, in exchange for a commitment to purchase reagents for some sexually transmitted diseases that we test for, and then flu as well. And so this is a $224,000 annual commitment for this agreement.
Okay. Any questions for Doug on this item? I'll entertain a motion.
Move to approve.
Should we not second just to mess with Doug for a little bit?
Like the way you think, DT.
I'll second.
We have a motion and a second. All in favor, please say aye.
Aye.
Opposed? Thank you, Doug. Appreciate it.
Thank you.
Item 8, Ms. Walker. Your first time at that.
Good morning.
Good morning.
I am rounding out my 4th week, so nothing significant to report other than the contracts, but thank you, Scott, for being here to support me through my first Finance Committee meeting. We had 55 contracts under $500,000 for the month of September, and nothing additional to report.
Great. Any questions for? Okay, thank you very much. We'll move to item I, and I will hand the yoke over to Chairman Weber as we'll convene the Board of Managers.
All righty. I'd like to convene the Board of Managers at 11:42. We have one item on the agenda, and that is the consent agenda. And I'd entertain a motion and a second for approval.
I move approval.
Second.
Okay. Any discussion from anybody? All in favor, please say aye.
Aye.
Those opposed say no. Didn't hear any no's. Motion passes. Next thing I have is convene in the executive session pursuant to Chapter 551 Texas Government Code. I don't know of any.
Yes, sir. I think we did have one item.
Yeah, there is.
We have one item, and Reverend Emerson has a question, I believe.
Yeah, before we go into closed session, I know I probably have asked this question before, and I know you probably given me an answer. I just don't recall. Can we be explained, I don't know by whom, to define a professional services contract? I mean, it doesn't have to take place today, but it would help me to understand how do we determine, or what determines a professional services agreement or contract.
Reverend, we can easily do that for you, and I would ask Daphne to come up with an explanation for you and for the other members as to what is considered that type of a contract and the differences. So we'll outline that for you, and we'll present it to all board members. And I think Daphne could easily have that ready before the next board meeting.
Okay.
Good.
So, Mr. Chairman, you do just have, I believe, one item. It's an item that Mr. Petty and I have together, and it is a very short explanation of an issue.
Robert,
And
have you got the room cleaned out over there for closed session?
yeah, well, we will definitely do that. We will, in your terms, we will clean out the room. So
that usually means I have to leave. So
is that like draining the swamp?
So we will do that, Mr. Chair, and I think it will take us probably 2 minutes.
All right.
All right. I'm not known for political correctness.
and then adjourn the meeting.
Okay, we're going to reconvene in open session at 12:04 hours. Having nothing to work on, I'd entertain a motion to adjourn.
So moved.
Second.
All right. You got that, Suzanne?
She's got it.
All right.
Leanne?
I have it.
Okay.
Thank you. Good afternoon, everybody. It's 1:01. I'll call to order the meeting of the JPS Health Network Governance Committee on the 22nd of October. I want to thank everybody for being here. Sounds like finance was planned to go late. They ended early, which is good. So we'll try to beat their record time, maybe to accommodate Amanda, who needs to step out a little bit earlier at a hard stop at 1:45. Thank you all for being here. I have not heard word or been notified that there are any citizens to address the committee. And I don't see any nodding heads or anybody jumping up to speak, so I'm going to assume that there are none. The first item of business is to approve the minutes for the August 27th meeting. As per, go ahead, who was that, Zim?
That's Zim, yeah.
Zim moves approval. Do we have a second? Dr. Weber, seconds. As per it being easier to vote online, I will assume that unless you say no to an item, then that item is approved. So are there any no votes to approve the minutes? Hearing none, I will declare that motion carried. I don't have much as far as a committee chair report, other than to say I had an opportunity to speak with the folks from Hall Render, who are doing the assessment of our ERM and our internal audit processes. Basically, this is an audit on the auditors. I had about an hour-and-a-half conversation with two gentlemen there from Hall Render, and I have no idea yet of the results of the audit, but I can tell you that they were very impressed, and it's a hats off to this committee as well as to Chairman Weber and the board as a whole for the fact that we allow Ron to come speak to us at every meeting unfettered without administration. They thought that was a really key, critical aspect of enterprise risk management, and really tipped their hats to this committee as well as the board as a whole for allowing that process to happen. So I appreciate Chairman Weber, you allowing us to do that. It sounds like that needs to be something that is kind of set in stone now for every meeting, because it was a note that was hit on several times in the conversation. So thank y'all for that. With that, we'll go to item number 5, consider governance committee reports, updates, discussion, and/or committee action and/or approval with our ERM update from Ron Skills.
All right. Well, first of all, thank you, Chairman Fisher. Actually, the Hall Render audit that's going on is for the compliance program effectiveness and how can we get better as a compliance function. And so, I'm looking forward to briefing that here with the governance committee once it's done. I think if we have a December meeting, it will be done by the December meeting. So let me see if I can get this, get the initial slides up here.
Sharon had a lot of difficulty, Ron.
We tested them. I think I might be successful this time.
All right.
All right. All right. So this first update for ERM is related to the area, one of our areas we haven't talked about in a little while, primary care delivery. As you all know, just as a reset, we have 12 enterprise risk management risks that we have an executive owner for. And what our goal is at every governance meeting, we'll give you an update on where we stand with a particular ERM risk so that you can ask questions of the executive responsible and we can assess progress against our goals. And so for today's presentation, we're going to have Joy Parker to give us an update on primary care delivery. Joy, are you on?
I am. Can you hear me, Ron?
Yes.
Perfect. All right. Well, good to see you all again. I presented earlier today. So today, talking about primary care delivery, I think from the very beginning when Dr. Duncan and I started this journey out together in 2017, we knew we wanted to ensure that we had measures of success. And that data points, the data would help to indicate whether we were really healthy as far as our ability to provide primary care services in our community. And at that time, we knew that there were some opportunities. And so Right now, as it stands, we measure the success of access to primary care services and that delivery on a couple of different metrics. One of those being just the ability, and this is a national standard that is monitored commonly in other ambulatory practices, is the access availability to the third next available new patient appointment for patients in the community. And so the goal for that is around 25 to 21 days or less. And so right now to date, we track that monthly. And so we sit currently with 11 of our 13 sites that are PCMH certified by NCQA, achieving that target. And so that's something that we keep up top of mind. That data point that we are able to monitor is done a couple of ways in partnership with the claim with our medical directors of every site, our managers, and those RN team leaders in those sites. And so they bring forward their scorecards. They action plan off of those. If there's any changes with staffing related to providers in that area, that is discussed, as well as another metric that we assess, which is around the current panel of those providers, which is essentially how many patients they can maintain and create access for both primary care new patient appointment access and follow-up appointments. So we assess that percentage of how full that provider is to gauge whether we need to make an adjustment or request for additional staff support. So those two metrics are big indicators for us from a current state as well as a looking into the future of what we need to do from a primary care delivery. So in addition to that, I would say with during the pandemic when that started, obviously we had a huge pivot and switch to telehealth services. I would say that it's been one of the biggest blessings, honestly, through this crisis, is that we have been able to very quickly offer telehealth services for all of our patients. And we make that, available to them in their internet site or Televox appointments that we message out, MyChart messages that we send out, and when they call the call center to let them know. This has helped us to not only, it's allowed us to be able to provide same day acute appointments for our primary care patients or seeking primary care acute care services. And in our partnership with the claim and the providers that they provide on our telehealth platform, we've been able to extend those hours upwards even to 11 o'clock at night through the week and on the weekends. And so I feel, I go back to even talking with Dr. Duncan and Robert and many of our other executive teams. This has been one of the biggest challenges to lift, but also one of the best benefits, I think, for our patients as it relates to how we provide primary care services to our patient population. The other metric I'd like to discuss really, and it's at the forefront of all that we do, is what the patients say and the patient experience. For us, when we look at our outpatient experience scorecard related to those metrics, our best and most improved year over year continues to be the question that says, was I able to get my appointment when I wanted one? And that has shown 1 to 2 points improvement year over year consistently. And so that is definitely a great indicator that our patients are actually responding and saying they are able to get access when they need that access for primary care. The other piece, and unfortunately Ron didn't give me a buzzer and I talked too much and too fast, but is just around the outcomes piece of this, right? When you think primary care delivery, it's more than access, it's how we're doing with outcomes. And I think we've definitely progressed a lot in the efforts that you've heard where we've achieved above even what we anticipated with DSRIP, which were really population health outcomes related to cancer screening, cardiovascular disease, diabetes, and how we have helped to support operationally our providers and our teams in helping to achieve those metrics, which resulted in better outcomes for our patients and also a financial benefit to JPS. And so we're extremely excited about that, and definitely that is attributable to when we look at primary care delivery in Tarrant County. So I think that's, I didn't speak to one-click and some other things, but a lot of those are the tactics that we're doing, but I'm happy to answer any questions, and hopefully this kind of meets the need for an overview for this.
I have one, Roger, if I may.
Go ahead, sir.
Oh, okay. Joy, when you said with the patient experience, you continue to show an increase in getting an appointment when I wanted one. Where are you now with that number? That top box stuff.
So the top box score, I've got all my metrics around me. Hang on just a second in front of me. Here it is. Top box, we moved at 55.5 percent for top box on that score. But I will tell you, Dr. Weber, when we started down that journey, it was around in the 30%.
Oh,
and we've
yeah,
definitely,
I remember well.
Yeah, and we've definitely seen, especially, and I know I'm going to come on later and speak about Access Resource Center and some of the different things that we've done from an access perspective, especially in women's health and some other areas. We saw point improvements of upwards of 30% in some areas. And so a lot of standard operating procedures, definitely data that drives transparency and accountability for us, and keeping that data in front of us at all times has been very beneficial for us in how we action plan to move forward.
Great, thank you.
Anybody else have any questions of Joy? Ron, I've got one for you. We spoke about it a little bit in our meeting run through. We're real close here to optimize, or I guess we are optimized, or at the edge of optimized, which is a great testimony to Joy and the team and everybody that's helped with this patient care delivery. That kind of puts us at a fork in the road, I believe. So do we take this off the list and replace it with something else? And then if we do that, how do we maintain optimized? Because I think methods of delivery are always changing. And we don't want to see the green arrow or the white star go backwards. I don't know. This is probably the one that we're furthest along on, I think, if I remember correctly.
It is. It's actually one of the 12. It's one of the furthest along in terms of its maturity, for many of the reasons that Joy talked about. And so it's been a while since we've had this discussion, but the goal for ERM, these top 12 lists, was the green arrow is an indication of where we are currently with our risk maturity management, and the white star is the goal. And as Roger pointed out, we're close to the goal. And I know Arena was getting metrics from Joy's team, and we believe that they'll be close, if not hitting that target here fairly soon. So the question would be is, obviously primary care delivery will always be important. And so, does it need to stay on the top 12 list, or do we kind of move it to more of a maintenance mode and kind of focus on the other areas and give us some room to maybe bump something else up would be a decision.
Is that something that we need to make? Is that for this committee, or is that a decision that you'll bring us back something? I'm fine with moving it and replacing it with something else, because all steps, have to get taller. But how do we keep a focus on it, and that it doesn't get, pushed under the closet, for 4 or 5 years, and then we're starting over from scratch?
Yeah, I think this is the next step in our maturation for ERM reporting. And so what I'll do is I'll make a note to come back to this governance committee with a formal proposal and with a kind of a new look at the 12. And if the metrics from Joy's team does put her at her goal, then it would be a different report out, and maybe not as frequent as what we currently do, but we still have some visibility on it. So if you're fine with at the next meeting, I'll come up with a proposal for the committee to approve in terms of how do we move the ones that are close to goal.
Okay. Ms. Dorothy, did you have something to say?
Yeah, I did. I was thinking that as we look at that movement, as part of hers is on outcomes, and maybe the follow-up with that would be over quality committee looks at outcomes. So once something mature, we're still going to be looking at outcomes, and maybe they could add it to their calendar to do it maybe once a quarter or biannual. I think that we have to think about how it's not going to go away. You don't want it to go away. You want them to still look at outcomes, and outcomes, since it's dealing with patient care, maybe that would be a part of we looking, could some of it go to quality? That was just a suggestion I had.
Yeah. Well, and I personally, I'm always a fan of, okay, we've met the goal, how do we raise the bar? But I do understand that there's thousands of things we can look at as this committee and as this hospital district. So I do understand that sometimes one may have to be put aside as something else is a higher priority.
Mm-hmm. I have a question. I'm a little bit confused about, because it's kind of in between quality and government now. So what are we looking at here, Ron? Are we looking at the process risk, or are we looking at quality outcome? And what is the implication when I say we have not achieved accredited for NCQA? Are we applying for NCQA? Are we in compliance or stay within the HEDIS measure? Or what are we looking at? I'm a little bit confused.
Yeah, so let me good question, DT. Just as a reset, because it's been a while since we've discussed this. The risk definition language is the overall enterprise risk definition for primary care delivery. And it is the risk that as an organization, for us to accomplish our organizational goals, this is the risk that we are wanting to mitigate against, which is the reason why it's posed in negative language. And I know that has been come up before, and that is, now I put a footnote saying that it's stated in the negative to say that this is what could go wrong. And so in this case, as it says, the primary care delivery system has not achieved accreditation in the expectations outlined by the NCQA patient-centered medical home standards. And so Joy and her team is their part of their focus is to maintain accreditation and also to mitigate the risk of us falling backwards. And so the point of having Joy to present is to give you, as a board member, a update on where we are with managing this risk from that standpoint. It is not meant to replace the quality measures that is done in the quality committee. It's just from a risk standpoint in terms of us, are we staying within the guidelines so that we can have a good opportunity to meet our goals from a risk management perspective?
Let me ask you this from a rules of engagement standpoint, like a better word for it. So when we're looking at this, I'm assuming that we are going through the NCQA certification.
Yes.
So if I have to look at that, I have to look at, are we piggybacking on the EPIC, assuming EPIC is paying NCQA for the HEDIS measure? Or are we certify ourselves? Because I know NCQA is a little bit strange in a way that even if you have EPIC, or even if, let's say, Blue Cross Blue Shield or Aetna or somebody else is using the HEDIS measure that is developed by NCQA and CMS publish it, we still have to be licensed by NCQA ourselves. Otherwise, they're going to ask EPIC or whoever that is to turn us in, or the insurance company to turn us in, because we're using the stuff that CMS approved, but to them it's their copyright or trademark. And that's one. And then from a risk perspective going forward, we may be using HEDIS, and let's say Blue Cross or somebody may say that that's what we use, but a lot of time, even if we use that, we still out of sync with them from a reporting standpoint, because until somebody owns that piece, you cannot challenge insurance. Sometimes the insurance is a year behind, but they're telling you that they're using 2020 measure, but they load in 2018 or 2019, and you will see the discrepancy. So who's, is it quality looking at it, or is it this body looking at it from that perspective to be able to challenge them if that is the case? Because I've seen it a lot of time. They say one thing, but they actually have different rules. Or is it IT?
I guess, Joy, do you want to, initially kind of speak to the NCQA measures and kind of how that fits into kind of what you guys look at and measure?
Yeah, NCQA is a great measure in the sense that it's comprised of over 40 plus standards that we have to meet, much like the Joint Commission when they come in. So each of those different standards, we do not piggyback off EPIC. Our team goes in and does like that registration and that contract with NCQA to come out and survey us. This last survey was actually a virtually done, an attestation to the data. It keeps us, we have a steering committee around this, but it's months and months of data gathering to show evidence of, certain achievements that that standard to be considered a patient-centered medical home. And that's everything from access to extended hours to ancillary wraparound support services, care coordination, social work, from, all different aspects. And so including quality metrics is wrapped into that. And so when Ron, and even before, when this measure, from a risk perspective was discussed, the NCQA standard really is the umbrella to say that primary care delivery is meeting the needs of a population. And so I think that was determined. But so hopefully that answers a little bit of your question of how we move forward with NCQA, what that setup looks like.
Not really. I'll tell you the reason why. You can do all that stuff, and then we don't get paid. It's still academic, right? So I want to close the gap between the patient medical home quality, finance, because contract management need to be enforced. Because if when you move toward more pay for reporting type, then if you can do all this stuff and then they apply the last year's rule and you're out of sync, and then nobody is looking at it. So we're giving up revenue from that perspective. And you can point to IT and say you didn't load it or you didn't challenge it. So how do we close that gap to keep them honest? That's right. Maybe that's my question. And that is part of this, assuming that, because that's the breakage. And then if they come in and they load old data and we have new data, different years, then they can challenge on compliance, and then if we don't have that act together, they can take some sample and say you are out of compliance, and here's your penalty. So those are some of the things I want to. This is new stuff, so I rather we do it right going forward and close that gap.
Right, and I think that's a great conversation we have that with a claim in IT, and I know that they partner on that, because you're right, from a reimbursement from a provider perspective, that sits on kind of the claim side to ensure that there is some credit in a sense that this achievement has been made. Excuse me. So DT, maybe if we need to take that offline and do some follow up on that, we're happy to do that.
Yeah, because this is not quality as in essence or quality, but it's quality to hold them accountable from a specs perspective. Right? Yes. So I'll be glad. We can take it offline, but I just want to make sure we close that gap.
But as we're talking about a risk and system-wide, enterprise risk management means that the stuff that one department can't control, we have a way of making sure that somebody picks it up, just what you were saying. So it is the system information that we have to make sure what Joy doesn't have control over, IT have it. So whatever that they're running into a barrier, that's the risk that you want to make to mitigate.
Yes. Yeah, I would, Joy, Dorothy said it exactly right. ERM is really designed to help look at all the different components of this big picture item. Joy represents primary care delivery from an executive owner, but there are many other stakeholders that have a bearing to play, IT being one of them, as well as a number of others that have to work together in order, of course, to accomplish these goals. So Dorothy said it exactly right.
It's a lot of hard work from everybody to deliver that kind of service from those measures, and I just don't want all that work that they've done go to waste because we did not close the gap on the last point.
Agree, DT.
Does anybody else have any questions?
Nope.
Okay, Michelle, are you ready? I think it's Michelle.
Yeah, no, it's me. It's me to start out.
Oh.
So it's
sorry,
first of all, thank you, Joy, for the report. So the first item on the agenda is the compliance program update, and the first update that I have for you is the key compliance headlines. And as you know, I try to pick out a few key headlines that are happening in the industry, enforcement actions, and other things to keep you aware of what's taking place. This first item is a national crackdown or sting operation that the Department of Justice recently completed in September across the country to crack down on fraud and opioid abuse. And it was there were 345 charged defendants, 51 federal districts involved, and more than 100 doctors, nurses, and other licensed medical professionals that were charged in this operation. These defendants were submitted or alleged to have submitted more than $6 billion in false and fraudulent claims to federal healthcare programs and private insurers, including more than $4.5 billion connected to telemedicine, more than $845 million connected to substance abuse treatment facilities, as an example. Obviously, we've talked a lot here at JPS about some of the controls that we have in place and try to put in place as it relates to drug diversion and opioid abuse. And so this is one of the primary reasons I wanted to draw attention to this. One, the size and scope of this. Obviously, it hasn't all been worked through the court process at this point. But also to highlight the importance from a compliance perspective of us keeping our eye on the ball in this area. The second item is Anthem. Of course, Anthem Blue Cross agreed to pay $39.5 million in connection with their 2015 cybersecurity breach. And it's been 5 years, but that's how long it takes sometimes to work through the process. What's interesting is that in 2018, Anthem paid $16 million for this same breach, and now did a final settlement for this additional $39.5 million. One of the things that they're citing is obviously the Office for Civil Rights that regulates HIPAA is the agency on this one. But Anthem is citing that they were the subject of state-sponsored cybersecurity attacks, some by China and other state-sponsored hackers, and so they cooperate with law enforcement in this process. And so one of the reasons I'm bringing this up, and I know I always have one aspect of cybersecurity that I'll bring up from time to time, because as I've mentioned at the last meeting, cybersecurity continues to be the #1 risk from a compliance and security standpoint during the pandemic as well. And so again, hence the reason for the emphasis. And then this last item is a the CMS price transparency rule that's going to go in effect in January of this next year. And it is the purpose of it is to increase competition and lower healthcare costs. But what it'll do is it'll disclose on a public website negotiated rates for inpatient or in-network providers and allowed amounts paid for out-of-network providers, which is a huge sea change shift for the industry. And obviously, it's not just JPS that's going through this. All healthcare providers are going through this. And so there is a committee that we have at JPS that has IT, compliance, HIM, Rory's group, and revenue cycle that are all working in various components around how do we comply with this rule when it goes into effect. The good news is that Epic as an organization, since Epic is one of the major medical records for most healthcare providers, is taking the lead and kind of helping us from a technology standpoint to comply with this. But I just wanted to make the committee aware of it as well.
Does it cover medical or pharmaceutical also as well, Ron?
I am not sure. I will find out on that for you, DT.
I think, if I'm not mistaken, by law, we cannot disclose pharmaceutical stuff, isn't it?
Yeah, pharmaceutical pricing.
Yeah.
Yeah, that was my understanding as well. I'm not sure, but I'll follow up on that. It obviously it's trying to give more power to the consumer to make it, healthcare services more shoppable is kind of the term that they've been using.
But then there is can you look also into how does out-of-network provider play with the new Texas SB 1264?
Okay.
Because 40% of the insurance plan that are governed by the state of Texas, then you have to go through arbitration. So I'm not sure if it's wise for us, or how do we display that number when the number is arbitrary and it's almost like a baseball style arbitration.
Mm-hmm.
So can you make sure that we look at that also as well, because
absolutely
we want to be in compliance, but we don't want to give up our rights for revenue leakage.
Right. Right. And obviously the concern from a provider standpoint is the competitive aspect of this pricing, in terms of the leverage that takes away from providers. But I made a note of that to follow up with the committee.
Right.
Appreciate that.
Because we don't have to do balance bill, but we can, if we feel, some people, give you an example, close to my heart is let's say anesthesia, right? Medicare rate is about 26 per unit of 15 minutes. So we have to determine, are we rounding up or rounding down, right? Mm-hmm. When we are 16, are we taking 2 units or we round down to 1 unit so that we can challenge them correctly? That's one. Number 2, people may be happy when Medicare paid $26 per unit and they got $28 or $30, they'd be happy. You wouldn't be surprised to see some people pay over $200 for that same unit. Depends on how you go to arbitration, and you pick the judge for that and the baseball style. That's why you see a lot of cancellation, because it's a race to the bottom. They cancel all the high contract providers so that they can bring that number closer to the bottom. So we got to be on that game if we're going to be being compliant. We got to know that, our option also as well before we display things and just giving up revenue like that.
All good points. I made note of that. Appreciate that, DT.
Mm-hmm. Thank you.
Ron, that last one is very, very complicated.
Yep.
When it says CMS price transparency rule, it sounds like it's going to be real easy.
Nope, it's very complex.
Very.
It's full of minds.
And I think that the full board is going to need to hear something about this issue, since it starts in January.
That's a good point.
Maybe at the next closed session of the board, you could give us. Sharon, I'm sure, is all over this, but.
Mm-hmm. Yeah, no, Rory and his team, as well as HIM, are heavily involved, as well as David Mendenhall's team. So I will take a note of this. I'll get with both the Roberts, Early and Browder, and Daphne, and we can put something together on giving a board an update at the next meeting.
Thank you. Mm-hmm.
Okay, and is a claim, anybody from a claim sitting with that group? Do you know?
I'm not sure, but I'll find out if a claim is involved in the transparency group.
Does that cover outpatient also as well? I mean, doctor's visit, or is it just strictly hospital? I forgot.
I believe it does. I believe there's an outpatient component. One of the things that it has is it has a minimum and maximum for negotiated charges for what's called 300 common shoppable services that I mentioned earlier, in a manner that they consider to be consumer friendly, to update this, and we have to update this information annually once it's provided. So it's kind of gives a range of those. So
yeah, it's for me it's kind of confusing, because you're not allowed to publish pharmaceutical, but there's a lot of pharmacy being dispensed under Part A. So how do we comply? Can you make sure, how do we comply without breaking the law?
Yeah. Okay. Oh, this is great. It's good feedback. Thank you guys for that. The next item is your favorite topic, which is board training. We talked about this a little bit at the last meeting, and what I had committed to do is at this meeting was to come back to you with a proposal of compliance training going forward. And so I want to share with you some my initial thoughts to get your reaction. So there in the board bylaws today, there are 5 areas that are highlighted in the bylaws in paragraph 2.5.6 that board members should get either trained or oriented on, and you can see those here. Compliance is one of those 5, and we've talked about that in the past. And so really my goal here today is to give you my proposal specifically on this one element from a compliance training perspective. Well, before I move to that, let me talk about this a little bit. So Within the bylaws, there's two provisions that specifically discuss compliance training. One, that there should be some form of annual compliance training given to the board every year. And we have latitude in terms of how that's structured and how we go about doing that. And then the second component is that the board is to develop some form of continuing education program. And I believe that Roger, at one of the prior meetings in, I believe, the SOPs, talked about a proposal around a broader continuing education program. Is that right, Roger?
I think that's correct.
Yeah, yeah, he was muted. Okay, yeah. So, so I'm not going to touch the continuing education. I'm really going to speak on the compliance training. So on this next slide, the team, Michelle and team, we went through all of the sessions that we've done here at Governance over the last 18 months. And on this slide, on items 1 through 9 are items that we have briefed the board in a very brief segments, 10 to 15-minute segments, that we've conducted this compliance training with you as governance committee members over the last 18 months or so. And then items 10 through 12 are proposed topics that we're planning to present to you in governance committee. Item 10 is Michelle will be covering here in a minute on professional auditing standards. So from a governance committee standpoint, there's two things. From a governance committee standpoint, obviously we can take some credit for this training that we've provided as training, to the governance committee, but it doesn't fully meet what the bylaws ask for because it's not given to the full board. So you as governance committee members, I believe we can make a good case or have some form of coverage as relates to compliance training. One of the things that Roger mentioned at the beginning was the Hall Render compliance assessment. And one of the things that the consultants was telling us in terms of his best practice for board members around compliance is to consider having board members take the same compliance computer-based modules that the staff take at JPS. And so there are 3 computer-based modules. There's a general compliance, there's a HIPAA, and then there's a, actually it might be 2, general compliance and HIPAA, that all staff take every year. And so the consultant suggested that, that might be an easy way of fulfilling the requirement, and you as board members can take the computer-based training modules as well. They're obviously high level and they're general in nature. So that's one thought. The other thought is on my last slide here in this topic for discussion is that we could provide, we could work with Roger as the governance committee chair and senior management to determine an appropriate board meeting going forward, that every year at that full board meeting, we will provide some annual compliance training, and you can meet that requirement through attendance of that board meeting. And if for some reason a board member cannot attend that particular meeting, that we can find a way to get that recorded and provide it to them. So that's my thoughts on this in terms of how we can kind of move forward. I'd love to get your feedback on it.
Ron, I think I think doing it through a board meeting is probably more conducive. It's important, but I don't know that it's something that we have to have a special meeting for. And I think generally that we could get that covered in, 45 minutes. And I can work with Chairman Weber and Mr. Bowes, as well as Robert Early, in finding a board meeting where that most appropriately fits, that doesn't, it allows us to have the time for the training necessary, but isn't taking away from other important board business.
Yeah, and
I also just want to say that was, in my phone conversation with Hall Render, if there was anything that we get a bad score on, it will be the fact that the board does not do the same compliance training as the staff. Where we had a lot of praise for having Ron basically having unfettered access to the board, we probably got the most criticism for not taking the same training as the staff. And they said basically if someone came in, it's the easiest steps are often the ones that are most overlooked. And if we come into a problem, we can say, yeah, we've had it, and that would probably go far to help us along.
Roger, could I say that when we get ready to do the training, maybe we could have it kind of like web-based training where if you're not there, you could go and click on it and read it, and we could, get a report on it. I'm doing a lot of web-based updates and stuff that is pretty kind of asking us to self-train, but the training that you're saying everybody could do, if we could have that where we don't want to take up a board meeting, but we could have it where you could click on it, read it, and that would be part of our training. Could we think about doing something like that? Make it a little web?
Yeah, Ron and I discussed that. Basically, if it's done in a board meeting, we know it's recorded. Then having just a snippet, that portion of the meeting, either edited out or put on the board portal in kind of a catalog of trainings, so that it's easier to keep up with which ones we've attended or which ones we need to see next or whatever else, and catalog maybe in date order and by title. So I think that would be really easy to do.
Okay.
Yeah, no,
Let me just ask another question. The one time y'all do that and I'm not there, how will I go back and get it?
I would imagine that we have a portion on the board portal, maybe in the briefcase, or I can't remember what they're called now, where you can click on training and then there'll be links there that just populate below it.
Well,
yeah. Here's a thought, Dorothy, on that, because I agree. It could be a meeting that a particular board member may not be there, and so there are ways. Again, I'm not an expert on the board portal, but there are ways that we could have the training recorded, have the board member who missed the meeting take the training, and maybe have some kind of attestation that that the board member clicks on to say that I completed that training, so that we can have record of it, type of thing.
Correct. You could set it up where once I do it, it prints out me a certificate, and I could provide it to you. I mean, that's what I'm thinking about. Okay.
Okay. I'll look into that. I'll on the details of that.
Ron, one of the things that I think you ought to consider if you're going to do it by computer based is have some questions at the end that need to be answered by whoever ever done the program. Because if it's just a matter of turning it on, waiting 10 minutes and saying I attested to do this, sort of defeats the purpose.
No, I agree. There should be there should be a quiz at the end, and that's how all of the staff training is. There are questions at the end, like you described.
Okay,
absolutely.
Here's a question that came up with the defensive driving course. Apparently in that course there are 4 or 5 times where the person doing the presenting catches you by surprise, such as one of the questions might be, Mr. X threw the following on the desk, and the right answer was the right arm. You know what I mean? You literally have to take and read the exam, or you can't do the final questions.
Some of us don't speak, so we don't know what defensive driving is.
I wanted to ask Dr. Weber, how do you know so much about defensive driving?
I got that from a neighbor.
I think that there's a way to do reasonable controls for this and to ensure that we're all compliant and to meet the satisfaction of whatever regulatory agency wants to ask for it.
I agree.
Do you think we need to have HIPAA training compliance like everybody else, since we'll sit on the board of a hospital?
I believe so. Yes. And that's easily done. And like I said, to Roger's point, we already have ready to go HIPAA training that's already in computer-based form. You as board members, if you decide to, we can have you guys to take that, and it could be done that way as well.
Can I submit the one I've done before? So skip that.
No speaky English.
We'll make it easy for you, DT. I'll help you fill in the bubbles.
Okay. Ron, how many sections is that training?
The HIPAA training typically, well, it depends on how fast people go through it. But if you listen to all of the material and there's some videos in there and so forth and questions at the end, it typically takes people about 30 minutes to complete that module for the staff. And then the general compliance training, which is kind of a broader training, is around 20 to 30 minutes. So if you take both of them, it's about an hour.
Oh, okay. All right.
Yeah.
Okay. All right.
Yeah, I think that'd be the whole board ought to be on for that.
Right. Okay.
Okay. Well, thank you. That's great feedback. And Roger, I'll just get with you after, and we'll come up with a proposal along with the senior management here.
That'd be good.
All right. Great. All right. The next section is, let's see if I can. Okay. Is the current board training for the governance division. I'm going to bring on Michelle Atkins to talk about internal audit standards. Michelle, are you there?
I saw her.
Michelle?
Yeah, I did too.
Can everyone hear me?
Let's see. Oh, here she is.
You're going to have to speak up. We can barely hear you.
Is that better?
No.
Yeah, no, you got to unmute, Michelle. Okay, now go ahead.
Using the phone here on the speaker. So, yeah, I got a big echo.
Her mic's not working. She's unmuted. Can't hear.
Oh.
I can't hear her.
Him up on her computer.
I'll send her the phone number.
Okay. All right. Well, while we're getting Michelle squared away, so we were prepared. We'll prepare to. Oh.
I was going to say we can go ahead and go through policies if you want, and then come back.
Yeah, that's what I was. You actually read my mind, Roger. That's what I was.
Hey, great minds think alike, buddy.
That's what I was thinking. So, let me advance forward to the policy section, and we'll talk about that. Okay. So, at this meeting, we have two policies for archival and/or approval. The first one is LD 2900, leadership structure. This policy basically spells out the leadership structure, the committee structure for JPS, and then it also spells out the executive management staff at a very high level. And the challenge with this policy is that one, it's not required per se by Joint Commission, because Joint Commission primarily requires that you have org charts for both the management and the board, and you have medical bylaws, and it's redundant in that way. But also the challenge with this is that since the executive management staff titles change so much, this policy has to change on an ongoing and regular basis, and it's hard administratively to keep this current and up to date. And so, in kind of going through this, we didn't see the need in having this, given the fact that we have the other elements that would meet the Joint Commission requirements. And so we're proposing for this LD 2900 to be archived.
Does anybody have any questions, comments, or concerns?
No, I agree.
To archive LD 2900?
I agree.
Mr. Fisher,
I'll take that as a motion from Dr. Weber.
That way, there's a question.
Mr. Fisher, I do have a question. Hey, good afternoon.
Oh. Hi, Janet.
Hi. Ron, quick question. Did we run this by our Joint Commission consultants to assure that the leadership Joint Commission standards are sufficiently answered by the org charts and the bylaws? Because we're going to take out, I think this policy was probably created to answer some of the leadership standards.
Right.
I'm sure that if we take it out, we're not going to have a gap.
Right. Well, actually, it's a good question, Janet, because I'm actually partly responsible for helping fill out the leadership chapter standards, and so there's, as you know, there's both the behavioral health and general leadership standards for Joint Commission, yes. And so we've completely filled out 160, almost all of the Joint Commission Leadership Chapter standards, and without necessarily referencing this policy. Now, to your question, we did not. I can't recall if at this point whether staff actually spoke with the consultants on this, but we did fill out all of the standards for Joint Commission survey, and we were able to do that without necessarily this policy, if that answers your question.
Assuming they were filled out correctly, yes, it does answer the question. The board is responsible for defining the specific responsibilities. So the org charts will not answer that. You have to actually define the responsibilities, and then the board has to say, what do we do if our delegated responsibilities are not being fulfilled? And I don't know that's in the bylaws for the board or not. I think perhaps it's not. So I'm just encouraging. I don't like the policy. I agree with you. It was probably fell a hole. But I think we probably need to take a very critical look at the leadership standards. I know we're seeing some gaps in the medical staff relative to these same standards.
Okay. No, I hear you. No, I appreciate that. I will say I have the policy in front of me. It's 3 pages, and primarily what it does is it designates who the executive staff are, who the medical staff are, and what our administrative authorities are.
Right.
And then it talks about that we have structures and committees that are designated in an org chart. So what I can do, because there's not a hard set, it's not a burning platform. What I could do is if the board would like, I could have the Joint Commission consultant to verify that this policy is not going to be needed before we vote to archive it, just as a final check, just to do that. So I'm happy to do that as well.
Mr. Chair, I would concur that before we do that we do go back and look at that, because Joint Commission, even doing sometimes when you're filling out what they are asking for, they come in and ask for something very specific. So I would think that you have a consultant, just use it to make sure that we don't need it. Okay?
That's fine with me. Ron, if you'll check with the consultant, we'll go ahead and table LD 2900 and to another date. Janet, thank you for the heads up, and we'll just make sure it's clear before we do it. How about LD 4200 and policy 4201?
LD 4200 and 4201 policy is the prevention of detection of fraud, waste, and abuse. In this case, the policy needed to be edited and amended to be updated with its language as it relates to the Federal Deficit Reduction Act of 2005 and other kind of more kind of semantics and formatting changes that were added. And so the other thing was that some of the procedures from LD 4200 were split out and put in. Some of the procedures were taken out of the policy and put into the procedure section from a formatting standpoint. So, so this is more of a update of this policy and or procedure with current language and ensuring that the procedure document was properly formatted.
Okay. Does anybody have any questions regarding 4200 and 4201?
No.
I'll ask for a motion to approve.
Recommend approval.
Dr. Weber with the motion. Is there a second?
Second.
I think Zim was first.
Okay.
Are there any no votes to the changes for LD 4200 and procedure 4201? Hearing none, I'll deem that passed. We'll forward that to the board for our next meeting.
All right.
Is Michelle back?
I'm back. Can you hear me?
Not really.
No.
Better, but not great.
Yeah.
How about now?
No. No, worse.
Yeah. Well, Michelle, do you have a headset that you can put on? I think that might help.
Call-in number. I sent you a call-in number into your email if you want to try that.
Hey, that's what I was using. So.
That's really strange.
What's that? Yeah, Michelle, I tell you what. Why don't you just come on over here to the OPC, and I will. We can kind of move on to other aspects, and let's see if Tim is on. Tim, while we're checking, Tim, can you hear us? Can you come on?
I am. Can you all hear me?
Yeah. Yeah.
Okay, great. And Michelle, I actually have a headset in here if you want to borrow it and see if that works. Okay, so we'll move on to.
We're on item D, I assume. For those following your agenda.
Yeah. So.
Take it away, Tim.
All right. I think Ron's just getting up to there.
Yeah.
So this slide is going to be our annual report out of the results of the surveys we send out at the end of each audit for feedback on how we did. And so for each of the audits here, you'll see how many surveys were sent out, how many we received back, and then in the chart below, you can see the scoring for each of those projects, along with the baseline goal we use for ourselves. So on one hand, we're really pleased with the results that have come in, that they continue to be positive and above our established goal. But on the other hand, you can see the return rate of the surveys isn't as high as we would like it to be. And so just a little information just so you guys know, for those internal audit departments that do send out customer surveys like we do here at JPS, many have the same struggle of getting feedback after an audit, or a significant amount of feedback.
Tim, before you get started, can I ask a quick question on that? Is return meaning they reply to the survey, or return means there's no delivery and you got the mail back? I just want to make sure I get the definition correctly.
Absolutely. So return DT means we got the survey back with their feedback.
With reply.
Exactly. And so what it is, it's an anonymous survey monkey. So we send a link out to the folks from the business side that we work with on each audit. Mm-hmm. And then they respond to that survey monkey, and we're able to monitor as the results come in.
Okay. Thank you.
Sure. So, in the industry, for those departments that do send out surveys like we do here, many have a similar struggle of getting a good amount of feedback after each audit. Typically, we're more prone to get responses if something happened to go wrong on the audit, or maybe people weren't happy with how the audit went. And so we've been discussing internally about some different or additional options.
What in the world was that?
This is a lot of fun today.
Yeah.
It's the twilight zone.
Yeah, sounds like we're good.
I had to locate it. It's off now.
Yeah.
Okay. So we've been talking internally. Just we do promote the survey throughout the audit at our kickoff meeting, at the exit meeting right before we send the survey out, and then I'm also sending reminders before we actually close out the survey monkey, just trying to get as much feedback as we can. But we're getting creative and thinking through some other ideas and maybe some additional steps we can add on to what we already do to hopefully get the response rate higher for our future audits. So any questions about the results or just our process?
No, and like we discussed in our briefing, typically the return on a survey like this is a good sign in the sense that everybody left happy. Nobody left the audit feeling like someone was attacking them, or those people that are doing the audit were unfair, or something otherwise nefarious was going on. I'm willing to bet that most of those audits that returned, or those surveys were returned, were generally overall positive. So, I mean, I look at it, yes, it's a shame that, you know, we're getting that kind of return rate, but I also look at it as a good thing that it seems to me that those doing the audit are doing it fairly and treating everybody with respect. They're getting the cooperation that they need. The auditors are cooperating with them. You know, when you're happy, you don't say anything, but when you're mad, you want to speak to the manager. So that's kind of how I view it.
At what percentage of the return can we deem that it fit the criteria where scientific enough for us to look at that and get some guidance from it?
Was your question, DT, at what point on the return rate can we actually gauge some statistical results?
Right, because if we
information.
If we have 10% return, then it's not. It shouldn't. I'm not sure if it's scientific enough for us to look at from statistics standpoint and make recommendation or changing things when we don't have that kind of participation.
Right, absolutely. Yeah, there's only so much information you can glean from, for example, on transitions of care, one response out of 9 that were sent out. Right.
Yeah, but I guess the other point here is from an internal audit standard perspective, in the IIA, Institute for Internal Auditors, I think has benchmarking data. Do they not, Tim? As it relates to, I don't know if they would keep a metric on percent return rate of surveys, but that would be probably something that we can look at as well.
Well, can I ask a question on?
Sure.
When you sent out, let's just look at transition of care. You sent 9. Who's involved in you sent it to? Is it the line, the directors? Who does it go to? Because I do find that when folks are happy, they are much quicker to hit that yes, yes, yes button. Mm-hmm. But when you have to say something negative, you kind of hold back a little bit. So who do they go to?
And it really spans the spectrum, Mrs. DuBose. We always send to the executive sponsor or sponsors for the particular audit, and then down the chain. So if we were working closely with a manager or director or several managers and directors, we would send it to them. And then even the non-leaders as well, if we were working with them throughout the audit. So it's really everyone we had meetings with, conversations with, we worked with on testing, regardless of their position, we're seeking the feedback. So it might look a little bit different on each audit, but it's really whoever we talk to.
Okay, all right.
Yeah.
Okay, thanks.
Sure. Yeah, but one of the things I know Tim and Michelle and I talked about was, in addition to sending the survey, and it is supposed to be anonymous, because I said, well, why can't we just call the other 8 people that didn't send it in? Well, we can't. We don't know which of the 9, for example, sent it in and which didn't. But what we could do is we can call all of them and just say, hey, we, as a part of the closeout process for the audit, one of the things we like to do is get feedback. If you've already turned this in, that's great. We don't know if you have or not, but just as a another reminder, and see if that maybe prompts additional. So.
Yep.
All right.
I was going to send Guido out and start knocking on doors, but Karen Duncan thought that wouldn't be a very good idea.
All right.
I thought it was quite good.
Yeah. Well, Michelle, have we stalled long enough for you to get on, or are you coming?
I've actually got Michelle here in my office. We're going to swap. In the presentation.
Yeah.
Well, y'all are creative.
This was a lot faster than running across the street, through the building, through the morgue, and all the way up. So sorry about that. I think it's my laptop is kind of old. And anyway, so with all those distractions, I want to kind of remind you that at the beginning of this meeting, the chair mentioned that we've had an audit of the auditors. And so when that happens, what happens is auditors get graded on their conformance with internal auditing standards, which is why I wanted to take a few minutes to go over professional internal auditing standards with this committee. The first thing, though, I wanted to share is, you can all hear me okay, right?
Yes.
Is the vision, of course, is the vision for the internal audit function. And so this is what we're trying to build and achieve for the future. It's a desired long-term effect. So again, we want to be a sought-after resource and essentially viewed as an essential function of the governance structure at JPS. The second one is to maintain constant vigilance, and I would add to that also communication with our stakeholders so that we can address the priority needs and highest risks of JPS and the board. And then the third one is to serve with professionalism, dedication, and always objectivity, which is extremely critical to the internal audit function. One thing I realized on this slide is I don't actually capture the sort of a simplistic definition of what internal audit is, and I want to just take a few minutes. It's just 4 little easy things to remember. It's independent, it's objective, and it's an activity designed to add value and improve operations. And so you can't really talk about internal auditing standards without talking about the Institute of Internal Auditors. And so as you see on the slide, it's an authoritative guidance and it provides a lot of functions for the profession. It's 80 years old, it's international, there's 200,000 members in 170 countries. There's 150 chapters, by the way, in North America, and Fort Worth, of course, has a chapter of about 400 members. And I just want to give a shout out to maybe one of our auditors who might be listening right now. He is our chapter president, Tevye Lawson. He's a Fort Worth IIA president. And then I serve on the board of the Fort Worth IIA chapter. And just wanted to mention, too, that the Dallas and the Houston chapters have about 2,400 members in those IIA chapters. So it's very large in the area. What the IIA does for us is establish standards, much like the AICPA establishes generally accepted auditing standards for external audits. The IIA does the same for internal audits. And they're the creator of what's called the IPPF. It's the International Professional Practices Framework. And there are 4 elements to that framework that are critically important to an internal audit. Ron, if you go to the next slide, you can see that the IIA has, the standards, the IPPF has 2 sets of guidance. One is mandatory, and so when auditors get audited, they're being audited on this mandatory guidance, and then they're making suggestions or recommendations based upon the implementation and the supplemental guidance of those same standards. So again, the 4 elements are the definition of internal audit, as we just mentioned, again, independent, objective, value add, and improve operations. And then the standards, again, that subset of standards are just like the gas standards that you would find on an external auditor. And we'll talk about that in just a second. And then there's the Code of Ethics. Code of Ethics has 4 principles for internal auditors: integrity, objectivity, confidentiality, and competency. And then there are 10 core principles, and I will go over those here in just a few minutes on a later slide. And then all 4 of those elements, it's really important that we have covered in our internal audit charter. Next slide, please. So this is a quick snapshot of the attribute in the performance standards that we're graded on. It looks like a short list. There's only 4 attribute and 7 performance standards. And again, very much like gas standards. But within the 4 attribute standards, there are actually 19 substandards and 70 specific conformance criteria. Under the performance standards, there is 33 substandards and about 134 specific criteria that we have to comply with. And so what I'd like to do on the next slide is hone in on the 1300 Quality Assurance and Improvement Program. That is a standard, attribute standard 1300. And that standard specifically says that auditors must perform annual self-assessments. And then they must have every 5 years an external validation of those assessments, which is in fact what we've had in terms of the audit of the auditor. So this slide shows you an example. Again, it's just pulling out 2 of those substandards for standard 1010. So 1010 falls under standard 1000, which is the purpose, authority, and responsibility of the internal audit function. And so as you see, a key conformance criteria is, does the charter contain all of those necessary elements that were described in the IPPF, as I just mentioned? And then the second one, B, it says, has the CAE discussed the mission of internal audit, which I'm about to do, and the mandatory elements, as we just mentioned, of the IPPF with management and the board? So the reason that we gave ourselves a partially conforms in that space is because we can't remember the last time we've had a meeting where we advised you of the IPPF and the mission of internal audit. And so when we did this self-assessment, this is an example, again, a snapshot of what we pulled out of that assessment to show we need, in red, document the evidence of the mission and the IPPF discussion with senior management and the board. In addition to this snapshot, I wanted to bring to your attention the 3 categories or criteria for conclusion. There's a generally conforms with the standards, meaning we meet the standard, or partially conforms, or does not conform. So generally conforms, believe it or not, is, although it sounds, it sounds mediocre in my opinion, but it's no different than getting what you would call an unqualified opinion on a financial statement. It's really the best that you can get. So again, as we look at this self-assessment in fact was performed just before we were audited, and we took note of not having done this, having this training with the board, and so we are serving that purpose now. On the next slide is our mission statement, and the mission statement again is put out by the Institute of Internal Auditors. Is to enhance and protect JPS's organizational value. We added the words and community value to ours by providing stakeholders with risk-based, objective, and reliable assurance services, advice, and insight. Again, the 10 core principles, which are part of the IPPF, once again, are demonstrating integrity. We talked about that. Integrity, competence were part of the code of ethics. Are we free from undue influence? Basically, are we independent and also objective? Aligns with strategies, objectives, and risks of the organization. Appropriately positioned and adequately resourced. Again, we may only have 3 full-time internal audit staff, but we do have the luxury of those contracts that you've approved to staff augment with CRO and KPMG as needed. So that does help the function quite a bit. Do we demonstrate quality and continuous improvement? Once again, that's what an external auditor came in to do, to audit us, to let us know how well we did. And then do we communicate effectively? Are our report and our briefs clear and concise? Do we provide risk-based assurance? In other words, do we weigh the cost benefits of doing an audit? And is insightful, proactive, future-oriented? I believe we've captured that in our vision statement. And then finally, do we promote organizational improvement? And again, I would submit that is what the purpose of adding value means. So are there any questions? I know I went fast. I'm so sorry for the distractions. Of the core principles, the mission, the code of ethics, the IPPF in general, and then the standards. So technically, altogether, there are 204 individual standards that we comply with and that we were audited against.
And I guess technically, Michelle, all the board members here get credit for having sat through now a briefing on the IPPF, and we can check that off now, right?
I can check it and make it generally conform. Yes.
Ron,
Thank you for your patience.
Ron, I have a question. Quick question. On the org chart, you have it's a direct line, but it's also not a dotted line, but direct line back to the CEO. So the question is, looking at that, if I'm not mistaken, number 3 is going to be questionable, isn't it?
What do you mean, DT?
Yeah, you lost me, DT.
On the org chart, right, you have a direct line, straight line into the board, but you also have a straight direct line, not a dotted line back to the executive. So just looking at from that perspective, the auditor may have some problem with independence on number 3.
Well, I mean, that's reason. Well, two things I would say to that. One is that we, one of the reasons why we had the independent review done by the auditor, Honkamp, on the internal audit function, was to take it out of our shop so we can get a third-party view to answer the question that you're answering, and you'll be able to see. We'll be covering that here in a minute, and so we'll be able to see their perspective on that. And then number 2, and then, oh, by the way, before I move off that, we're also going to do the same thing on the compliance side for Hall Render. And so, number 2, I think, it is traditional and actually standard practice for the chief compliance officer to have a dual reporting relationship with both the board and the CEO of an organization. Actually, that is leading practice in terms of that.
Okay.
DT, that's part of what Hall Render really gave us incredible props about in my conversation with them.
Okay. All right, sure. Thank you.
Anybody else have any questions for Michelle/Tim? Since I see Michelle's face and I see Tim's name.
We're distancing, like 6 feet.
Good. All right, thank you very much. I think that gets us covered down, does it? Yeah, to executive session. It is 2:18. Let's try to get this thing kicked off at about 2:20. So, control room, if you can kick out whoever needs to be kicked out, and everybody just hang loose. A few minutes here and we'll be done. We'll adjourn to executive session at 2:18.
Okay.
Thank you, committee. We'll reconvene back into regular session at 3:26 p.m. With no further business. I'll ask for a motion to adjourn.
So moved.
And I assume I have a second in there too?
Yes.
Got it.
And the third.
No, there's no votes, so this meeting stands adjourned at 3:26.
All right.
Everybody have